Good afternoon. I'm Simone Cavallaro, Director of the Stigler Center. Before we start, I'd like to express our gratitude once again to the healthcare and frontline workers, both in the US and abroad. Thank you. And thank you all for tuning in today for this webinar in our Political Economy of COVID-19 series, which explores the global economic and political implications of the pandemic with leading academics and experts. Today, we are happy to host author and former health insurance executive Wendell Potter and Booth Professor Neale Mahoney for a conversation moderated by Booth Professor Guy Rolnik on the impact of the crisis and its implications for the future of healthcare in America. Before we begin, please note, we are on the record and live streaming to the Stigler Center YouTube channel. Please feel free to share the broadcast on your social media. If you have any questions for the speakers, please submit them via the Q&A icon at the bottom of the screen. The last 15 minutes of the webinar will be devoted to answering those questions. As usual, views expressed by our guests are their own, not those of the Stigler Center or the University of Chicago. As you may know, the Stigler Center promotes and diffuses research on regulatory capture and the various distortions that special interest groups impose on capitalism. We have many initiatives to help both students, alumni, faculty, and the greater community stay connected and informed in this difficult period, including weekly episodes of our podcast, Capital Isn't, co-hosted by Luigi Zingales and Kate Waldock, focused on coronavirus-related topics. New coronavirus and COVID economy sections on our online publication, promarket.org. More upcoming webinars in this series with speakers including Thomas Piketty, Julia Anquin, Betsy Reed, Stacy Mitchell, as well as other speakers and events. So please continue checking our website and sign up for our newsletter to stay informed. Back to this afternoon, we look forward to an engaging conversation. But before we begin, please allow me to introduce our speakers. Wendell Potter is an author, journalist, and former health insurance executive. Earlier in his career as a reporter, he covered Congress, the White House, and the Supreme Court. He then spent over 2 decades in the health insurance industry, first at Humana and then Cigna, and served as head of corporate communication for Cigna before leaving after a crisis of conscience in 2008. He has authored multiple books on healthcare topics, including Deadly Spin, an insurance company insider speaks out on how corporate PR is killing healthcare and deceiving Americans, which was a prize-winning New York Times bestseller. Potter's commentary has been featured in publications such as Los Angeles Times, Newsweek, The Guardian, and The Nation, among others. Neale Mahoney is a professor of economics and David Booth Faculty Fellow at Chicago Booth. He is also co-director of the Health Economics Initiative at the Becker-Friedman Institute. He is an applied microeconomist with an interest in health insurance and consumer financial markets. His research has been published in top academic journals, and he has received coverage in major media outlets like The Economist, New York Times, and Wall Street Journal. Before joining Booth, Mahoney was a Robert Wood Johnson Fellow in Health Policy Research at Harvard University. He has also worked at McKinsey and for the Obama administration on healthcare reform. Our moderator today is Guy Rolnik, who is a clinical associate professor of strategic management at Chicago Booth, where he teaches classes on the political economy of regulation and the news media. He has over 30 years of experience in financial journalism, business, and politics, among others. For the last few years, his work has been focused on the dynamics of regulatory capture, a topic dear to the Stigler Center. And now, without further ado, I turn it over to our speakers. Thank you.
Thank you, Simone. Good afternoon, everyone, and welcome to our Stigler webinar, this time on the political economy of the coronavirus and the healthcare system. Today, we have a unique mix of speakers, a distinguished health economist from Booth, and an industry insider, but not the usual insider, but actually a whistleblower, or a better description, a turncoat, Wendell Potter spent most of his professional career as a senior executive for health insurance companies, helping them craft messages and influence politicians. But in the last decade, he moved to the other side, campaigning against the health industry and advocating reforms. Our goal for the next 55 minutes is threefold. First, we would like to understand how did the common US health coverage arrangements influence the average American faced with the pandemic. Second, we would like to understand better the political economy of the corona and healthcare related policy decisions taken in the last 2 months. Thirdly, we would like to ask what are the lessons or opportunities from this healthcare crisis. But first, I would like to invite Wendell to kick off with a short presentation, followed by a discussion of Professor Neale Mahoney. Wendell, please.
Thank you, Guy. If there is one industry that will weather this pandemic and actually, in my opinion, emerge with even more money on hand, it'll be the health insurance business. The top executives of the for-profit health insurance companies have known for quite some time and have even told their investors that this pandemic likely will not have a material financial impact on their earnings this year. One of the CEOs, Anthem's CEO, said at a Barclays conference in mid-March that his company could actually see a net savings because of all the elective procedures that have been canceled so far. Big insurers have been exceeding Wall Street's profit expectations every quarter, with few exceptions, since the Affordable Care Act was passed 10 years ago. While that law restricted some of the practices and eliminated some of them that they had been engaging in to maximize their profits, such as refusing to sell coverage to people with pre-existing conditions, the law didn't do a whole lot to curtail other practices that the insurers have used to maximize their profits. These practices fall under a broad category called benefit buy-down, is one way of looking at this. And that's a broad term that encompasses the various ways that insurance companies have, and employers that offer benefits, have been devaluing the benefits that Americans are, benefit plans that Americans are enrolled in. And these include shifting more and more of us into high deductible plans. And now the majority of Americans are in high deductible plans, meaning they have very high out-of-pocket obligations before their coverage kicks in. Requiring more prior authorizations before physicians can proceed with treatment or even prescribing medications for their patients. And increasingly narrowing their networks to keep a lot of physicians and facilities out of network. The reality is that the health insurance industry has only become really more powerful and profitable since the Affordable Care Act was passed. Here's just one example. United Health Group, which is the biggest insurer, announced first quarter earnings just last month. And as is typical with the company, it far exceeded Wall Street's expectations. And this was during the beginning of the COVID crisis. The company's revenues during the first 3 months of this year were up more than $64 billion, which was almost 3 times what it was during the first quarter of 2010 when the Affordable Care Act was passed. And over those 10 years, the company's stock price has increased more than 1,000%. United is not alone in doing so well. So are the companies that I used to work for, Cigna and Humana and Anthem and Aetna and some of the other big for-profit companies. They've almost constantly, almost continuously since the Affordable Care Act was passed, have exceeded Wall Street's earnings expectations. One of the reasons I left my job was because I was expected to be a cheerleader for high deductible plans. I knew that these plans would be very good for health insurance companies, but not so much for many Americans, and I was right. Most Americans are now enrolled in these kinds of plans. That's especially true of people who are buying their coverage through the so-called Obamacare exchanges. High deductible plans were relatively rare when the ACA was passed. Now they're prevalent, and deductibles have tripled over the past 10 years. Some insurance company plans now carry deductibles of more than $7,000 for an individual and $15,000 for families. The rapid growth of these plans has created a problem that was not so much a problem when the ACA was passed. But now increasing numbers of Americans are underinsured. That means that the deductibles are so high relative to their income that they just simply don't have enough money in their pockets or their bank accounts to cover the care that they need before their coverage kicks in. The Commonwealth Fund last year found that about 40% of people who buy their coverage through the Obamacare exchanges are now underinsured, and about 1 of every 3 people who get their coverage through their employers are now underinsured. And as a consequence, Americans with high deductible plans are having to make trade-offs, like avoiding going to the doctor or cutting back on medications. And these high deductibles is putting, I think, the country in a particularly precarious or difficult situation when you are comparing us to other developed countries, because people, even with insurance, are more reluctant to get the care that they need, go to the doctor, get testing, and have the worry of how much it will cost them if they do have COVID-19, and how much it will cost, how much they will have to bear out of their own pockets if they do have the virus. So I think it is probably exacerbating our problem in that people, even with insurance, are delaying the care that they need. The second way insurance companies are able to avoid paying claims is through very aggressive prior authorization procedures. In a recent survey by the American Medical Association, physicians said insurers are requiring more prior authorizations than ever. And a sizable percentage of those doctors said that prior authorization required by health insurers for drugs, tests, and treatments has led to serious or life-threatening adverse events for patients. And it's also a factor, or has been in the early stages of this pandemic. I've learned that in many cases, patients were stuck in the hospital while they were waiting for their insurance companies to grant permission for them to be moved to a rehab facility, for example, for follow-up care or rehab care. The third way that insurers are saving money at patients' expense is through narrowing their networks, or kicking doctors and hospitals and other facilities out of their networks, which of course is contributing and increasing the odds that the patients will get surprise bills. Networks are continuing to get narrower and narrower. United, which is the country's largest health insurer, has been especially aggressive in recent months in culling its networks. Hospital-based radiologists, anesthesiologists, and emergency physicians, all of whom are really on the front lines right now, have reported receiving contract termination notices from United that went into effect just as the pandemic was intensifying. United actually gave these doctors and these physician groups an ultimatum: accept 50 to 60% cut in reimbursement, or you'll be going out of network. And that's the dilemma that a lot of these physician groups are in right now. The American Society of Anesthesiologists reported in February that more than 40% of those who responded to its survey said that their contracts with United have been terminated in recent months. And in many hospitals across the country, there are now no in-network anesthesiologists to treat United patients. So when you add up the effects of high deductible plans, aggressive prior authorization, and narrow networks, the consequences, whether they're intended or not, are substantial and adverse to patients. But they're very beneficial to health insurers. Insurance companies continue to take in more and more revenue every year, and increasingly from us as taxpayers. But they pay less and less for our care, and they make it harder and harder for us to get the care that we need from the hospitals and doctors we want to use. One potentially troubling development for insurers is a steady decline in the number of Americans who get their coverage through their employers. The employer-based system has been crumbling for the last 2 decades. Fewer people are enrolled in employer-sponsored plans now than there were in 1999, even though the population during that time has increased by 50 million people. But the decline has accelerated during the pandemic. Over the past 6 weeks, 30 million Americans have filed for unemployment compensation, And that is just the people who were able to file. The Economic Policy Institute, SMA, said as many as 14 million others who could not file or were not eligible for unemployment compensation may also have lost their jobs during this pandemic so far. And not only have most of those people lost their jobs, but a very significant percentage have also lost their health insurance. Despite a steady decline in their commercial membership, insurers have nevertheless been reporting record revenues and profits. And they've accomplished this by raising their premiums and also by competing aggressively in the government-sponsored programs, Medicare and Medicaid in particular. The number of people enrolled in Medicare Advantage plans, which are operated by private insurance companies as an alternative to traditional Medicare, the number of people enrolled in those plans has more than doubled since the Affordable Care Act was passed. And some major insurers now get far more money from the government than from private payers. During the first quarter this year, for example, United Health Group reported receiving 2.5 times more revenue from government payers than from private payers. So that's been a development that has been occurring over recent years, but the revenue has really switched for these big insurers. Now they're getting most of it from government payers. Another troubling development for insurers is a growing support among Americans for more sweeping reform than the Affordable Care Act accomplished. Public opinion polls that have been conducted in recent weeks show a majority of Democrats and independents are supportive of expanding the Medicare program to include all Americans, knowing that that would eliminate private insurance companies as we know them now, or the role that they play in our lives now. But so far, though, the insurance industry has been able to kill or shape reforms that might have a negative impact on earnings. They've been very successful in doing this over many years. So unless lawmakers at both state and federal levels implement changes to curtail the influence of money in politics, certainly through campaign contributions and also from lobbying, that likely will continue to be the case. But bottom line, the insurance industry is poised to have a very profitable 2020, while most Americans are going to be finding that their health insurance premiums very possibly could go up significantly next year, and they may have difficulty paying for the care that they need this year, increasingly so in the future.
Wendell, thank you. Professor Mahoney, please.
Thank you, Guy. And Wendell, it's great to be on the webinar with you. So I think I want to start by sort of agreeing at a very high level with Wendell that the US healthcare system costs much more than it should, and the quality leaves much to be desired. What I really have enjoyed about reading Wendell's work and hearing to him speak today is his depth of knowledge about health insurers in the US, and certainly health insurers deserve some of the blame for problems in the US healthcare system. I don't think they're the only party that deserves blame. There's enough blame to go around from the providers, so hospitals and doctors, to politicians who I think sometimes put interests outside of patient health front of mind, to the insurance industry that Wendell speaks about. So I think there's a whole host of problems that I think need to be solved to improve the U.S. healthcare sector, and I'm looking forward to either talking about some of the specific things that Wendell brought up or talking about potential solutions, or how sort of the issues interact with the coronavirus sort of crisis right now. Guy, I don't know what would be of most interest to your audience.
Okay, so before we go to look at the other players in the healthcare system, Wendell, I would like you to you focused a lot in your talk and in your writing on the cost and the extent of coverage of healthcare in the U.S. But before we go there, I'd like to hear from you. Do you think that we have learned anything from this crisis about the quality of care in the U.S.? Does the high number of deaths in the U.S. has, in your mind, to do with the way the system is designed, or just with the late response or even denial of the virus by the administration?
I think certainly much of many of the problems we have are the result of not acting, or the administration, or we as a country not acting quick enough. But I do think that our structure has made us particularly vulnerable. We don't invest, for example, in my view, as much as we should in public health. Only about 3%, it's been estimated, of what we spend on healthcare in a given year in this country, which is about $3.5 or more trillion a year, goes to public health and our public health infrastructure. So that's one thing. The other, though, is that our structure, we have such inequalities in our healthcare system, and we're seeing that a very high percentage of those who have COVID-19, who are hospitalized and who die, are people of color, and generally those who have means are not as adversely affected. So our system is one that we ration care in this country based on the ability to pay. So I think that is showing up. And also the structure that we have in place is also showing, again, the vulnerabilities or the insecurity of coverage. As I mentioned, the employer-based system has been around for a long time, and the majority of working-age Americans get their coverage through the workplace. Well, as these jobs are, so many jobs are being eliminated, or people are being furloughed or laid off, in many cases they lose their coverage. But also just the movement, as I noted earlier, to high deductible plans and making our citizens pay more out of their own pockets for care before their coverage kicks in, if they have coverage, is also, I think, a factor. So I think that the basic structure of our healthcare system is showing just how foolish we've been over many years to have a healthcare system that favors the well-to-do and punishes those who are not, and certainly that would include communities of color in particular. We have such great disparities in healthcare in this country that is much more than any other developed country in the world.
Thank you. So maybe let me rephrase the question. Yeah, I wanted to rephrase the question to you and actually repeat the question, but only slightly change it and say that we are the US is the richest democracy in the world. So why did we end up with close to 70,000 dead, and we're still counting?
Great. So let me try and give an answer to that, and then wanted to touch on a couple points Wendell made about high deductible plans and about employer-sponsored insurance. So I'm not an epidemiologist, but I've been following, I think, the literature quite closely over the last 4 months. And it seems like, largely the administration, but probably also Congress has made a series of mistakes. The first being in late January, early February, when we knew it was only a question of time before there were going to be sort of community spread in the United States, that, we took the strategy of sort of burying our heads in the sand and hoping that everything would magically go away, rather than building sort of a robust test, trace, and isolate system. I think the second mistake was when we did shut down the economy to basically reduce the spread, that we didn't use that time to build, again, the capability to test, trace, and isolate. What that's going to mean is we're going to have these, I think, sort of rolling lockdowns over the next many months because we don't have the ability to put out the sort of small fires before they become large blazes. So I think this has been, a failure of leadership, a failure of implementation, and quite sad, given, I think, the U.S. track record of, being able to, I think, get things done when it's needed, and it, obviously in this circumstance, that's not been the case.
So, Neale, there is a lot of discussion in the last months about alleged trade-offs between the economy and the and healthcare concerns. And last month, you wrote an op-ed explaining why, in your mind, actually the entire discussion on trade-offs is wrong. Can you share it with us? Can you explain why?
Yeah, no, of course. So, I'm an economist. Economists study trade-offs. That's like the key frame in our models. But, when I wrote this op-ed, I think Trump had been tweeting out, let's not let the cure be worse than the disease. I think more recently we've had competing sort of economic and health task forces within the administration. And I do think in this case, sort of the trade-offs between the economy and fighting the virus are overstated for two reasons. One is, I think the best thing we can do to get the economy going again is to contain the virus. We saw that the economic activity plummet before the stay-at-home orders went into effect in Washington state and many other states. We haven't seen economic activity sort of rebound immediately after Georgia and other regions have lifted stay-at-home orders. So I think we know from that and from other evidence that it's not just the restrictions on economic activity which is suppressing the economy. It's people are choosing to stay home because they're rightly concerned about the virus, which means if we want to get the economy going again, we need to combat the virus so that people feel comfortable going to restaurants, going to barbershops, etc. That means that money spent on testing, tracing, and isolate has a double dividend, right? It reduces the spread of the virus, but also gets us to a point where people feel comfortable going out. So I think that trade-off is overstated. I think the other trade-off which is overstated is when we think about redistribution or of social insurance. So let's think about unemployment insurance. The classic models, the classic framework is, on the one hand, we want to transfer resources to people in bad states of the world when the value of money is high. On the other hand, we know if we make unemployment insurance more generous, that it will provide a disincentive for people to find jobs, to engage in job search behavior. And so during regular times, we want to balance these two forces. Today, we don't want people to go out and look for jobs. And so the classic trade-offs of, do we want to provide a more generous social safety net, or do we want to provide incentives for people to go out and find a job, don't apply, and probably won't apply for a number of additional months until we get to a point where we want to stimulate economic activity. So I think in both of those realms, these standard trade-offs, I think, can be overstated. There are still trade-offs. Obviously, we don't have infinite money, but I think we want to be careful on not just falling into our old habits of sort of on the one hand this, on the other hand the other, because I think these trade-offs are less acute at this moment.
So Neale, a follow-up questions on that. Just before our webinar, I looked at the stock of United Healthcare, and like Wendell said earlier, it's almost close to all-time high, which is pretty amazing. You think that health insurance company in the middle of the one of the biggest, if the biggest health unexpected disaster that we had is close to all-time high. But actually, in many ways, if you look at S&P 500, it's not that close. So it's only 15% or 16% down from all-time high, and probably something like 40% higher where it was 3 or 4 years ago. And the question, you wrote in that article that I mentioned that a lot of the discussion about the policy proposal today this is like a fig leaf for corporate cronyism. And the question is, do you think that we are the best way to bail out the economy is through bailouts to Wall Street, to the largest companies, or actually there is a better way to bail out the economy and the employees and consumers? And if we had chosen that option, we might have it might have been more efficient, and might be when we look at the stock market, we might see that we didn't bail out the equity stakeholders, but rather the rest of the stakeholders in the economy.
Great. So I guess 2 points, which I think partially answer that. I agreed with nearly everything Wendell said at the beginning of this webinar, but I think the spirit of this is disagree. So I'm going to disagree with his argument based upon profitability of health insurers this year. I think there are lots of issues with health insurance in the United States, but I think even if our health insurance system was perfect, we would expect insurers to make large profits this year, basically because they've sold an insurance product projecting high utilization of the product this year, and utilization has been low for reasons which are outside of their control. So they're going to make a lot of profit. Even if they were operating perfectly, they would make large profits this year. I think their profits really don't tell us much about the underlying problems, which I think I agree with Wendell around. About the point of sort of bailing out shareholders versus, I guess, what is the talking point, bailing out Main Street. I do think that the way capitalism works is that shareholders receive returns in exchange for risk. And so that it is I think, reasonable and appropriate thing to do when there are shocks to let the people who earn profits because of the risk to bear losses because of the risk. So I think, I haven't been following, all the details of how Treasury's been structuring the loans and other financial supports to different corporations. But I think, one objective to keep in mind is that we should allow people who signed up to take risk to bear losses. And that's how capitalism is supposed to work. And when that doesn't happen, I think everybody has reason to be concerned that the system is somehow rigged.
Wendell, just before the Neale mentioned the politicians, and just before the outbreak, I believe it was Super Tuesday, and Bernie Sanders, the presidential candidate who focused his campaign on health reform, just a few days before all hell broke loose, lost the race. Do you think that after this crisis, there will be a political will for a significant health reform?
I think there will be a debate about it. And I do think that there will be more will potentially than we've seen in the past. Again, I think that there will be no denying that the system of employer-based coverage is anything but secure. The other thing is the burden that health insurance poses to employers who do offer health insurance to their workers. Increasingly, employers are finding it challenging, and I think as their businesses emerge from this, it'll be more and more apparent that having the additional burden of providing health care to workers is one that needs to be looked at and addressed. So I think that there will be. I think also it's becoming quite apparent that health insurance companies in particular are not interested in getting us to universal coverage, and that they've erected a lot of barriers that make it difficult for people to get the care that they need. I agree with what Neale was saying a bit ago. Certainly the insurance companies are not the only problem that we have in this country. Certainly a lot of blame lies with healthcare providers too, drug companies, big hospital companies, even physician groups. One of the problems though, and I think this will become apparent as well too, is that insurance companies don't have the ability to control healthcare costs as much as we've been led to believe. And I think there should be some discussion about that. By that I mean that the hospital systems have grown very, very large and powerful, and it's increasingly difficult for even the biggest insurance companies to negotiate rates that would trickle down, if you will, to patients in terms of reduced cost, certainly to their employer customers. They're very much unable to really negotiate in a meaningful way with drug companies. Otherwise, we would see we wouldn't see drug prices continuing to escalate as much as they have. So I would hope that policymakers would begin to look at our system broadly and see where these problems lie, how they can be addressed, and also see that our system of financing healthcare leaves a lot to be desired and has in many ways contributed to spiraling healthcare costs, and done nothing to meaningfully bring down the number of people who are uninsured, and we're even seeing more and more people underinsured.
Neale, what Wendell just mentioned about the hospital, does it have to do a lot with the consolidation of hospital, the concentration and the market power?
Yeah, I think one of the things that I've been concerned about, and we've seen increasing evidence in the academic literature, is the role of hospital market power. That if you go to many markets, so especially mid-sized cities, there's really only one hospital system in town. And that means that health insurers basically are buying from a monopolist hospital system, and that results in high and increasing costs for health insurance coverage, borne by employers, borne by employees through reduced paychecks, borne by the government sometimes when they're paying for Medicare Advantage or other forms of insurance. So, I see this as an issue. There's a phrase in the economics of antitrust where it's hard to unscramble the eggs once hospital systems consolidate. It's hard to break them up again. So I think it's the options for how to deal with hospital market power, I think involve either sort of a public option, which is going to bring the government's negotiating power to bear, or price controls we've seen in Maryland, or something I think even more ambitious. I don't know what Wendell's view is about the optimal path forward, and be happy to chat with him about that or whatever else you think is appropriate, Guy.
So before we go to Wendell on that issue, so correct me if I'm wrong, but one of the first economists that actually wrote about the healthcare economics many years ago, 70 years ago, was the late Nobel laureate Kenneth Arrow. I believe he had a very famous paper in 1953 or something like that, and we are fortunate here at the Stigler Center in our blog in 2016, just before he passed away, to interview him on various issues, regulatory capture, and we talked about healthcare system, and we specifically, that was with the first Bernie Sanders campaign, and he said, single payer probably is the answer for the healthcare system in the U.S. And of course, people who know the work of Kenneth Arrow, he was no socialist. That's for sure. And still, he thought that it makes more sense in terms of efficiency. Do you think that this is the efficient way to go, single payer? And of course, does it have any, politically, is it makes any sense to pursue that direction at this point?
So I guess my view of sort of healthcare reform is, I think we all want to get to a place with lower costs and universal coverage. And I've spent probably the last 15 years thinking about this. I don't think that anybody knows the best way to get from point A to point B. It could be single payer, but at least personally, I think given the lack of strong evidence, that I would support something that's sort of a more phased approach. So for example, a public option, which I would support, I think has three advantages. One, if there's a public option, let's say on the Obamacare exchanges, it forces prices down and forces quality up because private insurers have to compete with the public option. Two, I think it would reduce costs that private insurers have to pay. Basically, the elderly in the United States have the choice between a public option that's sort of regular Medicare, and roughly 35% of the elderly buy a private health insurance plan through Medicare Advantage. And for a variety of economic reasons, Medicare Advantage plans actually pay hospitals much less than the same insurance plans would pay to provide commercial insurance, so insurance for the workplace. I think a public option does that. And what I like most about a public option is if it works well, it will grow because people will sign up for the public insurance plan. And if the plan has issues, then it won't grow as fast. And so I see that as a prudent way of expanding the role of sort of government provided healthcare, which might end up with single payer, but is not putting all of our eggs in one basket. And if we had all of our eggs in single payer right now, we'd all have Trump insurance, right? And I don't think we would want that. So taking a prudent approach and sort of scaling up the role of government, I think is just sort of a better course of action.
Okay, so Wendell, can you quickly weigh in on that because we have to go to the Q&A, please.
I think a public option certainly is worth considering as well too. I think that in my view, a single payer healthcare system is where we should wind up. I think even if Bernie Sanders had been elected president, and even if we have a Democratic Congress, if we had a Democratic Congress and he were president and Senate, it would still be difficult for us to get to a single payer system with one piece of legislation. So I do think probably moving forward on an incremental basis is the way to go and is the most politically possible way to go. I think a public option should be considered once again. 10 years ago, or during the debate on what became the Affordable Care Act, I was very much an advocate for that. The devil's in the details and how it's structured and what rules are established that would make it absolutely viable. The consolation prize, if you will, when the Affordable Care Act was passed, was funding to create or help for the creation of so-called co-op plans, nonprofit co-op plans around the country. They didn't last long, partly because the big insurance companies were able to game the system to go in with low premiums. And you have the advantage of scale too. These big insurance companies that were already in place were able to make do, if you will, or go to weather the storm with artificially low rates until their new competitors were out of business, and that indeed happened. So it depends on how it's structured. I think the public option should be considered and likely will be considered the next time we have a real debate, and that probably will be next year. One thing, just back to what Neale was saying, I do agree about hospital consolidation. I would say that in some regards, though, there's been some kind of a self-defense on the part of hospital companies. I managed communications around many different acquisitions that Cigna made over the years when I was there. Cigna grew, as most of the other big insurance companies did, through large acquisitions, and some large and small over many years, to the point that in hospital systems or hospitals around the country were seeing that they were at a significant disadvantage. So when I say self-defense, I would imagine that it could be argued that a lot of the hospitals felt that it was necessary for them to combine, to consolidate, to have at least some ability to negotiate from their perspective, from a position of strength, by bulking up or consolidating themselves in the face of all the consolidation that took place over a number of years on the insurance side.
Okay, so let's go to the Q&A. We'll start with a few consumer questions. So Carl would like to know, he has a union plan with a $100 annual deductible, and he'd like to know how unusual is that nowadays?
I would start by saying it's fairly unusual. Some union negotiated health plans are certainly better in terms of out-of-pocket obligations of the members or the enrollees. Some of the benefits are richer. What I would say to union members, though, is that while it might be better than a health plan that someone else you might know who is not in a union plan, it's certainly not secure, as we have seen during this pandemic, during the debate on what be in Nevada back earlier this year. The culinary workers were not at all favorable to Bernie Sanders' position on healthcare reform. But as it turned out, a lot of those members actually wound up voting for him because of the awareness that even if their benefits were pretty good compared to others, there's certainly no assurance that coverage will be there for them if they're the victims of a layoff, as many of them have been.
So a follow-up question on that. Would you please comment on the AARP's endorsement of United?
You know, it troubles me a bit. AARP has been working with United Healthcare for a long time, selling, in fact, I myself am enrolled in an AARP Medicare supplement plan, which is a United plan. They've had a business relationship with United for a long, long time. It's an exclusive relationship. So that, to me, that is problematic. They have such influence as an organization, certainly on Capitol Hill as well, too. It's a very well oiled machine, if you will, when it comes to public policy initiatives and their ability to lobby on behalf of its membership. But its membership, with this partnership, they are certainly favoring one insurance company over another.
Neale, perhaps a question addressed to you. Why don't employers push back on paying higher premiums for coverage that is worse? And this is, of course, Wendell can take it also.
It's a good question. My understanding is there's two factors which limit employers' ability. One is they have very high switching costs. Right? So if you have, you're a large employer, you have a contract with United, and you're thinking about switching over to Cigna or Aetna, you have to convince all your employees that it's a good idea to switch over. That might involve forming new relationships with primary care providers, and that upsets a lot of people. They're unwilling to do that. And so they sort of absorb the higher premiums each year. I think another point in this connects to what Wendell was saying is there's been a bunch of consolidation among health insurers. And so sometimes there's only 2 or 3 options. And again, that reduces competitiveness in the market.
That's very true. There are not a lot of options for big employers. I will say that in the insurance business, the companies covet each other's large employer accounts, and the way that they've continued to grow or to maintain membership, or to at least try to curtail some of the membership losses, is to what's referred to as stealing market share. And there's a great deal of that goes on. So when a big contract comes up for renewal, a big employer will work with its consultants, its brokers, to determine what else might be available. But as Neale said, that can result in a lot of disruption for employees. The networks of physicians that are available in hospitals can change, benefits can change, plan structures change. So there is that, and that discourages some employers from moving forward to make that kind of change. It does happen because sometimes the increases, the fee increases, are so substantial that, or service is deemed to be inferior, that that would promote a big employer to shop around. But there aren't a lot of places to shop.
So we have a question about the business model of the health insurance industry. So auto insurers are giving back a portion of premiums to the insured as there are fewer claims. Should healthcare insurers do the same?
Healthcare insurers actually will need to do this. Will need to do that to a certain extent, depending on what their medical loss ratios look like as we end this year. But that, I mean, the Affordable Care Act requires that insurers spend at least 80 to 85% of what they take in premiums on healthcare. If that is not happening, then the insurance companies have to issue rebates to their customers. Usually it goes, the rebates go to their employer customers, but that could indeed probably will happen if we do see that insurance companies are not spending as much on claims this year as they'd anticipated, yet their premiums haven't taken a hit, and they wind up with a medical loss ratio that dips below that threshold. They will by law have to issue rebates to customers.
Okay. Charles McWade would like to ask, didn't the ACA want higher deductibles in exchange for better catastrophic coverage? Seems like each round of reform results in more government that makes the system even worse.
So I guess a couple things on the history of high deductibles, but maybe Wendell can also chime in. I think the big push for high deductible plans was the Medicare Modernization Act of 2003, which sort of set up the tax exemptions for these health savings accounts, which are paired with high deductible plans. And then basically since that point, we've seen a steady increase in high deductible plans, especially people with insurance from work. It's now something like 30% of people. what is the ACA done? I think one thing where there may be some misperceptions is for the vast majority of people who buy insurance on the Obamacare exchanges, even though the plan nominally has a high deductible, there's basically government support for the cost sharing. So these are the CSRs, which kick in. Something like 75% of people on the exchanges have their deductibles covered to some extent. So I think there may be a little bit of sticker shock there, but it's probably not as bad on the exchanges as it might seem. But certainly employers have been basically just rolling out these high deductible plans more and more.
So we have a question about technology. Considering the immense growth in the use of artificial intelligence and machine learning technology in many industries today, what role do you see telehealth playing in the future of the healthcare insurance market?
I would say will play a major role, a bigger role going forward. I think this period of time, this pandemic, is making it clear that that is something that is more available to patients. More physicians, I think, are coming to see it as the only way right now that they can keep their patient visits. So I think it's going to continue, and I think in many different ways as well too, not just in medicine, but in dentistry and other aspects of healthcare. I think you'll see growing use of telehealth.
Okay. Eric has a question. How should policymakers deal with the rising gig economy and the lack of regulation around it for treating workers as employees with sponsored healthcare benefits?
I can jump in here. I think the employer-sponsored health insurance system, right, was a historical accident. Right? We set it up in World War II when we had wage controls and firms wanted to attract workers, and their sort of end run around these regulations was providing health insurance benefits. And I think we should use this opportunity to move away from sort of tying health insurance to employment. I think the solution here is to make things like subsidies on the exchanges more generous so that people in the gig economy can get health insurance which isn't tied to their work. I think if the solution to this is just to force like gig employers to provide health insurance, we're not using this opportunity to make sure that when you lose your job, you don't lose your health insurance.
I agree with that completely. I think that this is another reason to take a look at our employer-based system. As Neale said, it was an accident, and increasingly, people are in the gig economy by choice or necessity, and a lot of the drivers for Uber and Lyft and Postmates and the other companies preferred, in many cases, to have their status as a contractual worker, not as a full-time employee. So I think it is absolutely an opportunity for us to take a look at our employer-based system, which, by the way, was something not so many years ago Republican lawmakers were calling into question and questioning why we would continue with that system. So it should be something that should have bipartisan support. That said, among the biggest champions for continuing it are the insurance companies, because much of their income from the private side comes from companies that offer coverage. So that industry will certainly want to try to protect it and perpetuate it.
Okay, so the last question for both of you calls for your optimism here, because we want to end with a positive note. And so before public option became a keyword in healthcare, economists, when they said public choice, actually they meant the economic strand of public choice, the Chicago School in many ways, and the collective action problem. And we have one of our participants asking, why do either Wendell or Neale think there will be a change in healthcare costs? Everyone except consumers benefits from the current system. Everyone makes a lot of money and can raise prices at will. So why should we expect any change in the system?
I can go first.
Sure.
Unless Wendell is chomping at the bit. I think politicians don't always respond to voters, but when something is a hugely important issue for voters, politicians will eventually react to it. And I think we've got to a point with the cost and coverage where, I think just the forces of democracy mean that politicians, I think, do want to provide additional coverage. And what do we see at first? We see Biden proposing Medicare to people 60 and older, right? Which targets exactly who we think are going to be the swing voters in Wisconsin, Michigan, Ohio, Florida. So I don't think we get from 0 to 60 immediately. We first address the issues of the most pivotal voters, but I do think pivotal voters care, right? This is number one issue for many voters in the 2018 midterms, and I assume it will be number one or number two this November.
I agree. And I think we've seen, looking back over history, that it takes a decade or so after the last attempt to reform the healthcare system that we have a debate once again. I think we're at that point. And I think also more people are aware of the shortcomings of the current coverage that they have, the vulnerability of that coverage. And I think we did see, certainly in the Democratic primaries, that healthcare was the top issue that motivated, or at least that most voters said that it was their top concern. So I agree with Neale. I think there will be, at least on the Democratic side, a lot more support for moving beyond the Affordable Care Act, whether it's tweaking or changing the Affordable Care Act or moving much beyond that. We'll have to see, but I think there will be quite a bit of debate, and I think some changes that are going to be made in the future.
Fantastic. So we ended with a positive, optimistic note. We have to wrap up. I want to thank all our participants, Professor Neale Mahoney and Wendell Potter, and we hope to see you all in our next webinar. Thank you and bye-bye.
Thank you, Guy. Thanks,
Thank you.
Wendell.
Thank you, Neale.